So, good afternoon, everyone. I am Dr. Aparna. So, I am a consultant clinical immunologist and pediatric rheumatologist from KIMS Cuddles. So, today we are going to see about immunodeficiency disorders that we see in everyday practice. So, how we'll diagnose these disorders with subtle clues and few symptoms of laboratory investigation that can actually lead to a serious manifestations. So I'm giving this talk on the eve of World PA Week that's happening in this week. So I will be dealing with a few case scenarios, and then I'll be talking about how to deal with it. Not moving. Yeah, sorry for the technical issues. So we all heard about primary immunodeficiency. So this is a Jeffrey Model Foundation 10 warning signs. So this is the basic thing that we all read about during our MD days. So even during my MD days, I have read this 10 warning signs only. But can we diagnose PID only with these 10 signs? No. So is it called PID? No. So nowadays it's called inborn error of immunities, and then there are like 555 inborn errors of immunity, and there's 17 phenocopies which are due to totally of 504 different mutation, and this has been published in the IUI's recent 2024 update. So why the name has been changed? Because it's not just a immunodeficiency, it's a immune dysregulations, and there can be like sometimes upregulation. There is a abnormal. It's not always a deficiency. Sometimes upregulation also can be there. So there is sometimes dysregulation can be also be there. That's why it's called inborn errors of immunity. So it's not called primary immunodeficiency. Coming to the case one. So the case one is a 9-year-old boy. So even though the child presented symptomatic since 9 months of age, the child presented to a immunologist only at 9 years of life. So at 9 months, the child had a symptom of Guillain-Barré syndrome, and he was treated with IVIG. Again, at 1.5 years, he had anterior horn myelitis, which was treated with IVIG. Later, he had multiple episodes of pneumonias, recurrent ear infections. He had persistent diarrhea which, due to giardia, and he had meningitis, and he had septic arthritis due to streptococcus pneumonia. And then later, he presented with acute gastroenteritis with AKA. So when we looked at the family history of this child, and it's always important in case of primary immunodeficiency to put a three generation pedigree chart so that we know which type of inheritance is there. So in this case, we have found that there is a X-linked history is there. There are multiple sibling deaths in the family, multiple male deaths in the family, either due to paralysis or pneumonia or cyanopulmonary infections. So this child has an X-linked history with a multiple cyanopulmonary infection with a neurological manifestation. So on examination and presentation, the child had pallor and grade 2 clubbing, and the tonsils were absent. On immunological investigation, child had hypogammaglobulinemia. So the child had pan-hypogammaglobulinemia, which means like the globulin levels are low in IgG, IgA, and IgM, so involving all the fractions. And on flow cytometry, we found that the B cells, that is CD19 cells, are absent. So the diagnosis was made as X-linked hypogammaglobulinemia. So the treatment for this child is we have to start this child on intravenous immunoglobulin therapy, and we should target the trough levels of more than 500 mg per deciliter. It's not just starting an immunoglobulin replacement therapy giving monthly. So we should make sure the trough levels are maintained above more than 500 so that they'll be like infection free and then they have better quality of life. So for the neurological manifestation, child was started on physiotherapy and rehabilitation. The main thing is like for a pediatrician point of view, we need to know what vaccines to be given and what vaccines not to be given. So the live attenuated vaccines are completely contraindicated. So this child had initial presentation with acute facile paralysis, had meningoencephalitis. So all these things are probably attributed to OPV that child has received. So OPVs should not be given to this child, and we should tell the family also if there is any other sibling, and they also should not receive pulse polio vaccines or oral polio vaccines, because like the other kids in the family can excrete this polio virus, and then the child who's immunocompromised will acquire the infection. So coming to the other vaccines like inactivated vaccines, even though we can give, but the antibodies, it's absent, it's completely absent in this complete absence of B cells. So they will not produce any antibodies. So that it's not harmful, but the benefit is unlikely because the antibody response is 0. So this child, even though the case had like multiple infection, in a normal normal without the immunological investigation, how do we identify these kids? So when you do an RFT LFT, if you see the globulin fraction, and also if there is any albumin globulin reversal is there or globulin fraction is less, yes, we can consider hypogammaglobulinemia in this kid. So when to suspect inborn error of immunity? So I have then initially Jeffrey Model Foundation has like I said before, there are like 10 warning signs they have given, but is the 10 warning sign is enough? Because as the inborn error of immunity spectrum is getting wider, there are like a lot of symptoms that we should take in consideration. So does a common organism cause inborn error of immunity? When do we suspect inborn error of immunity? When the child is coming from a common organism. If the common organism is like recurrent or persistent or leading to an ICU admission, or the disease is very severe and they are not responding to an antibiotics, and even with the Streptococcus pneumonia presenting with a severe HLH, and if it is occurring in an unusual site, so all those time also we should suspect inborn error of immunity. Even with the multiple staph sepsis, it can be like a phagocytic disorder. Multiple streptococcus infection, it can be an antibody deficiency. So we should always suspect even in a common organism, but if they have a recurrent or if they have a severe manifestation. So we all know there is an unusual or opportunistic infection, we have to suspect inborn error of immunity. Infection due to a less virulent organism, like the first case indicated, like due to an OPV virus, OPV vaccine, or due to a BCG that has led to a disseminated BCGiosis, or a rotavirus vaccine lead to a rotaviral infections. So in those cases also we should suspect inborn error of immunity. And of course we know the recurrent sinopulmonary infections, recurrent ear discharges, recurrent deep-seated abscesses, we should suspect. Apart from that, if the child is having recurrent diarrhea or like features of very early onset IBD, in those cases also we should suspect inborn errors of immunity. So we all know that the family history is important. Like from the first case I have told, we have to look for a 3-degree pedigree and then find out is there any sibling death or anyone is having similar history in the family. Apart from that, autoimmunity due to like autoimmune cytopenias like Ivan syndromes, unexplained ITP, ITPs or autoimmune hemolytic anemia, refractory to treatment, and any multiple rheumatological manifestation if they have, we should suspect an inborn error of immunity. Even a severe allergic reactions like eczema and atopic dermatitis can be due to an inborn error of immunity. Features of lymphoproliferation like hepatosplenomegaly, cervical adenopathy, and or any other adenopathy they have, and mild or subacute prolonged fever if they are having, that can be due to an ALPS or ALPS-like disorder also. So in those cases also we have to suspect inborn error of immunity. Of course, now the new spectrum of autoinflammatory disorders have come, and if the patients are having recurrent fever, periodic fever, unexplained fever, but you think like it can be some viral infection that keeps happening, but when you evaluate the child, you notice that there is some amount of periodicity, then you should think of inborn errors of immunity. So, and last but not the least, in case of HLH, if it's a primary or case of mostly secondary HLH due to dengue scrub we used to see, but in the severe form of secondary HLH sometimes can be due to an underlying inborn error of immunity also. So coming to the clues that help us to pick, of course, history and examination are the main important things. In the history part, so clinical history is very, very important. Family history is important. And what are the vaccines? Because like even the live vaccines can have manifestations. So that has to be asked. and what are the organisms that the child has got, because based on the organism, we will be able to pinpoint which arm of immunity has been affected, and the age of presentation, definitely, because like T cell defects have very early presentation, and B cell defect generally are protected in the initial 5 to 6 months because of maternal antibodies. And finally, there are few laboratory features that gives us a clue, and immunological investigation that helps us to pinpoint the diagnosis. And genetics is, of course, the uh, mainstay of diagnosis. In case of T cell defect, they generally have a early presentation, then in less from 2 months only, they are like very early presentation also they can see. And they'll have recurrent respiratory tract infection, they'll have diarrhea, they have various viral fungal infection, they can have bacterial infection also. In case of severe combined immunodeficiency, they have infections like PCP. And if in case of hyper IgM syndrome also, they'll have PCP infections. So all these things should be kept in mind. So if it's a cryptosporidium, and there is a high chance it can be a hyper IgM syndrome. In case of B cell defect, they generally seem little late because they are protected from the maternal antibody. So it generally starts from 5 to 7 months, and they'll have a recurrent sinopulmonary infection. There are few B cells defect which have autoimmunity as a predominant manifestation, like events, autoimmune hemolytic anemias, ITPs. They can have some amount of lymphoproliferation. We can have arthritis as a presentation. Coming to the phagocytic defect. So phagocytic defect also, I'll be like in detail, I'll be dealing in the subsequent slides. So few clues is like in history, you can see like they'll also have very early onset presentation. They'll have recurrent skin and soft tissue infection. They can have bacterial and fungal infections. In case of complement defects, they also can present at a varied age group. They can have recurrent infection due to an encapsulated organisms. Sometimes they'll have rheumatological manifestation like lupus also. So the next case, so this is a 17-year-old boy. Even though the presentation started at around 5 years of life, he presented to the immunologist at only 17 years of age only. So this child had a recurrent URTI. He had recurrent episodes of loose stools requiring admissions, and the child was managed as a celiac disease. And follow-up, child also developed immune thrombocytopenia, having mucosal and skin bleeds, recurring steroids, and child also had STOT station. However, there was no significant family history. On examination, child had clubbing and bilateral crepitation. So in investigation, in hemogram, we found that child was having thrombocytopenia. But on RFT, LFT, when we have done, we found that the globulin was low and the albumin globulin ratio was reversed. So this gives a clue that the arm of immunity that is involved in this case is antibody deficiency only. So we have done an IG profile in which we have found that IgG, IgN was low, and we have done a lymphocyte subset for this kid. The B cells are normal. So we have further analyzed the B cell by a B cell subset analysis. In this, we have found that the switch memory B cells were low. So this is a classical case of CVID. So those who are having hypogammaglobulinemia, the low switch memory B cells with the child having infections and autoimmunity. So this is a spectrum of CVID disorders. So even though nowadays, like there are a lot of monogenic forms of CVID, you have to do whole exome sequencing in this cases also. Those who are presenting at adolescent or adult as an adult also. So coming to antibody deficiency, so generally based on the investigations, we can say like profound or reduced or absent B cells with a severe agammaglobulinemia, severely reduced immunoglobulins, then we say it is a X-linked agammaglobulinemia. But yeah, nowadays there are AR and autosomal dominant agammaglobulinemia also. The next spectrum of antibody deficiency is like CVID phenotype. They will have severe reduction in at least 2 serum immunoglobulin isotypes. B cells can be normal or low normal also. The case that I have described, it was normal, but subsequently on B cell subset analysis, we have found that memory B cells was low because the maturation of B cell was affected. The third is like hyper IgM phenotype, but nowadays it's been declassified under combined immunodeficiency. And the last is like either a subclass deficiency or isotype deficiency or a functional antibody deficiency. So this functional antibody deficiency, we can do when we give a vaccine to the child, but they will not produce any antibodies, and we can find out using that. So those patients sometimes have a normal B cells, but the vaccine response or when they have an infection, they will not have that much good response. So that is also one class of antibody deficiency. So the clues for antibody deficiency is like the age of presentation is 5 to 7 months. They'll have a recurrent cytopulmonary bacterial infection. Enteroviral infection is a very important thing because like once they get the enteroviral infections, it's very, very difficult to eradicate them and very difficult to treat them. Like the first case I have discussed. So, an autoimmunity in the form of ITPs, EVAP syndromes, autoimmune hemolytic anemias, arthritis, lymphoproliferation they can have. So, in simple investigation, you can see like low globulins or albumin globulin reversal. Coming to the next case. So, next case is a 3-month-old male. So, child started to develop whitish KD lesions since day one of life. Initially, they thought it was normal, the local practitioner, and later it started to persist. So they thought it was oral thrush and treated accordingly. But during the course of 1 to 2 months, the child developed white maculopapular lesions also that was seen all over the skin. And later, when the child presented to us at 3 months, child also started to have high-grade fever. So on examination, we found that the child did not have any BCG scar. And the child was having oral thrush. He had a maculopapular rash with a whitish lesion over the back and the buttocks. He had a diaper rash with a perianal erythema and the peeling. There was a fungal lesions in the scalp also. On systemic examination, he had crepitations bilaterally, and otherwise the CVS and abdominal examination was normal. So this case, presenting with oral thrush, now with an acute febrile illness and like a prolonged some skin fungal infections, and the child was having absent BCG scars. So investigation we have done for this child. So even with the hemogram, this child gave us a clue that this is an inborn error of immunity. So in TLC, we found that even though TLC was normal, when we have looked at the differential, there was a severe lymphopenia was there. So the absolute lymphocyte count for this child was 880. So we have done a lymphocyte subset for this child, which showed an absent T cell and absent NK cells. That is and had only B cells. So this is a T negative, B positive, and NK negative skin. So this is a common mutation for males. We generally see X-linked. This is an X-linked skin, and this child had a mutation in IL-2RG gene. So coming to the lymphopenia, when do we suspect this child is having severe lymphopenia, and when do we have to refer to an immunologist? So for a children less than 12 months, we take lymphopenia as ALC less than 3000. For our older children, we take ALC less than 1000. So the lymphopenia can be due to a SCID or non-SCID causes. So what are the non-SCID causes? So SCID is like a severe combined immunodeficiency. The other combined immunodeficiency, which are not as severe as SCID, is called severe combined deficiency other than SCID. So they also have lymphopenias. And in case of severe sepsis, also sometimes they have a lymphopenia. So if you do a serial values, you will know whether the initial presentation only had lymphopenia and only one value having lymphopenia doesn't hold as effective as like when you have a serial lymphopenias, when you think that sepsis is the reason for the lymphopenia in those cases. So the other cause could be idiopathic T cell lymphopenia also as a cause. So I want to highlight that. So we always look into ALC count, and in that too in less than 12 months, ALC less than 3000 is considered as a lymphopenia. So we have to keep and watch so that we can pick up the SCID or combined immunodeficiency at an earlier age before they have multiple infections, so that the quality of life will get improved. We can prevent the child from mortality, and then the morbidity can be better. So this is the next case. So this is a 2-year, 4-month-old case. So the child was initially presented at 9 months with a subacute intestinal obstruction requiring a surgery. After that, the child had multiple episodes of LRTI and fungal infections requiring antimicrobials and antifungals. At 25 months, again, child presented with a subacute intestinal obstruction requiring laparotomy. Later, the child presented with autoimmunity in the form of thrombocytopenia autoimmune hemolytic anemia. So the child was given steroids at this point. So when we saw the child was having oral thrush, fever, respiratory distress, and also we noticed the child had vitiligo. So apart from this child had autoimmunity in the form of autoimmune hemolytic anemia, thrombocytopenia, vitiligo, and had a lot of infections also. So on basic investigation, basic laboratory investigations, we found the child had anemia, even though lymphopenia, like it's borderline for this age group is like more than 1,000, we take it normal, but that was like almost just borderline. And child had thrombocytopenia with elevated CRP counts. So because of the presentation since being early and having multiple infections, including fungal and bacterial infections along with autoimmunity, we thought could it be some hypomorphic variant of SCID or a combined immunodeficiency. So we went and did a lymphocyte subset in this child, and we found that child was having a low CD3. That is, T cells were low, even though B cells and NK cells are normal. So we have done a subclass analysis of T cells, and we have found that the naive cells were low compared to the memory T cells. So the naive cells are the ones that are seen in the babies before exposed to antigen. So once the antigen is exposed, they will all convert into memory cells. So when in a newborn period, the naive cells were more compared to memory, that is like almost 70 to 80%. In case of adolescent, the ratios get reversed. And this child, when we saw, the naive cells are like very low and the memory cells are high, suggesting it is a combined immunodeficiency. So we have done a whole exome sequencing in this child, which showed a compound heterozygous RAG1 mutation, which is a SCID variant. Since it's a compound heterozygous and a hypomorphic variant, this child also had autoimmunity in the initial presentations itself. Coming to the management of SCID, so infection-wise, we have to treat based on the bacterial and fungal infections. So cotrimoxazole prophylaxis for a PCV infection. If they have infection, we have to treat it. If they don't have, like, it's better to give a prophylaxis because they are more prone for PCP infections. So those patients who has received BCG vaccine, so we have to look whether they have any features of BCGosis, because like these patients, the most of the SCID patients, they will not able to react to the BCG vaccine, and this BCG vaccine will lead to disseminated BCGosis in most of the cases. So this I was highlighted in the first case because the first case did not have a BCG scar, even though the child has received the vaccine. So that is an important pointer or a clue that we have to look into it and consider it. So if a child was having disseminated BCGosis, we have to give HRLE because BCG is inherently resistant to pyrazinamide. Instead of giving HRZD, we have to give HRLE. If no manifestation, we have to give prophylaxis. The next is like we always have to look for CMV infections. So if a baby is a negative for CMV and mother is tested positive, either IgG or a PCR, so it's in Western world, it's always better. They say like better to avoid breastfeeding because all the SCID baby has to go for transplant. So during transplant, if they have exposed to all the CMV infection, it will be very difficult for the transplant success. So that's why they generally recommend to avoid breastfeeding those patients. So IVIG replacement therapy we have to give till the time of transplant. And of course, hematopoietic stem cell transplant is the mode of treatment. And vaccines, we should avoid all live vaccines, BCG, OPV and all. So live attenuated vaccine, even if you give, the benefits are unlikely. Because even these patients, SCID patients, they will have difficulty in producing antibodies. So the live attenuated vaccines, the benefits are unlikely. Coming to the clues for severe combined immunodeficiency, we have seen 2 cases till now. The usual age of presentation is like from less than 6 months, they can start presenting, but the presentation varies based on the severity of mutation. So they can have recurrent diarrheas, cyanopulmonary infection, extensive mucocutaneous candidiasis, they can have failure to thrive. So one important thing is like these patients should not be when we are planning to transfuse this child, we should always give an irradiated blood. So if you don't give a irradiated blood, that itself will lead to a graft versus host disease. So they will develop rash and T cell hyperreactivations. So regarding the vaccination, so they can have a disseminated BCG or varicella, disseminated varicella if they receive these vaccines. And in case of milder or moderate forms of T cell defects, they can have autoimmunity in the form of ITP, Zeman syndrome, arthritis, like the case had with Iligo. These patients have increased predisposition to viral infection like CMV, adenovirus, parainfluenza virus, varicella virus, and enterovirus. They can also have a high risk for fungal infections like Candida and also for Pneumocystis jirovecii. So in laboratory features, we always look for the ALC counts and reduced globulin fraction, and then albumin globulin reversal. And the next line is like we have to go with the immunological investigation, later confirm with the genetic diagnosis. Coming to the next case, so this is a 9-month-old boy presented with the blood in stools. So when a 9-month-old, when they started to wean the child and they started introducing cow milk, so we general thought is like this is a cow milk protein allergy. So if it is a boy and the child was having blood in stools, it's better to do a CBC to rule out VAS. So in CBC, we'll look for thrombocytopenia and mean platelet volume. So that gives a little idea before even going for a invasive investigations and all. So always we should put a 3-generation pedigree to look for any X-linked history or other histories like eczema, cyanopulmonary infection, skin or mucosal bleed. We have to ask in the histories, and hemograms to look for platelet counts and mean platelet volume less than 7 is suggestive of VAS. So later this can be confirmed by a VAS protein expression in flow cytometry, and we can do a whole exome sequencing to confirm it. Some patients present little late because of the mutations. Some hypomorphic variants, they'll have a little milder presentation of VAS also. Coming to the next case. So the next case is a 3-year-old boy. So he had 2 years of life. He had a cutaneous abscess over the left eyebrow, and he was conservatively managed with antimicrobials. Later, at 2.5 years of age, he had a cervical lymphadenitis, for which incision and drainage was done, and the pus culture grew staph raised, and he was managed with cloxacillin and clindamycin. At 3 years, he presented with a progressive swelling over the middle of the anterior chest wall. So when we went and had a little chat with the parents, and we found that the elder sibling had like some history of abscesses, and there was an arthritis also, which was managed with methotrexate, and there are few episodes of abscess over the ear pinna or on the left knee also requiring antimicrobials. So this case suggests a male and a female in the family was affected, and most predominant manifestation is like cutaneous abscesses, and one's organism is isolated, being a staph aureus, and the female had autoimmune manifestations also. So coming to the investigation of this child, so this child had a elevated TLC, so not so high, but almost in the upper range or the towards the higher end with the neutrophilic predominance. So the platelets are always on the higher end, and there are few values which showed thrombocytosis, and inflammation was elevated for this child. So this was the investigation done for this child. This child had pneumonia also, and we can see CT showing lymph node mass that is actually leading to a bony protuberance by pushing the bone. However, there was no bony erosions. So we have done a further investigations. The FNAC from that swelling, again we isolated Staphylococcus aureus, and TB workup we have done for this child, which was negative, and HIV was non-negative. Coming to the database, so this is a 3-year-old boy. He had a recurrent history of abscesses, lymphadenitis with the elevated inflammatory markers, neutrophilic leukocytosis, and thrombocytosis. So the provisional diagnosis in this case was primary immunodeficiency with phagocytic disorder because of the recurrent abscess and lymphadenitis. This was more towards a phagocytic disorder. So when to suspect a phagocytic disorder? So the clinical presentation is like skin and soft tissue infection. That is like in skin, they can have abscess, impetigo, cellulitis. In lymph, they can have suppurative adenitis or lymphadenitis. They can have gingivitis or internal organ abscess or osteomyelitis. So the classical organism isolated in phagocytic disorder is Staphylococci, Serratia, Salmonella, or Mycobacterium infection also can happen. In fungus, generally Aspergillus is one of the common organism in CGD. However, they can have Candida nocodia also. Generally, viral infections are not commonly seen in phagocytic disorders. So the phagocytic disorder can be classified as one with reduced number of neutrophils or functional defects. So the functional defects are the CGD, leukocyte adhesion defect, or others like Shiida-Higashi or MPO, myeloperoxidase deficiency. In case of number, if the numbers of total neutrophils are low, it can be a severe congenital neutropenia or a cyclical neutropenia. So I'm just giving a brief about leukocyte adhesion defect and the CGD. So in the leukocyte adhesion defect, when you ask the history, many of the patients will have delayed separation of umbilical cord. So they generally have, even though they'll have swelling, then they'll never have pus formation. So it's generally a sterile collection. So these two are two important pointer for leukocyte adhesion defect. Apart from they will have gingivitis, periodontitis. So LAD and CGD, both of them will have an elevated TLC count. But in LAD, generally it will be like 20,000 to 50,000, maybe more than that also. Sometimes the total leukocyte counts go up to 1 lakh also. So they'll have a neutrophilic predominance because like the numbers are produced, but because like they are not able to control the infection, the bone marrow will keep on producing the neutrophils, but neutrophils won't be able to reach the site of infection. And apart from this laboratory manifestation, they can have an elevated inflammatory marker also. The classical organism seen in LAD is like a Staphylococcus, E. coli, Pseudomonas, Candida, and Aspergillus. In case of CGD, the commonest presentation is like pneumonia, abscesses, lymphadenitis. They'll have a recurrent liver abscess also. They can manifest as osteomyelitis. So these patients also will have elevated inflammatory markers with a neutrophilic leukocytosis and a thrombocytosis. So the common organism is like catalase positive organisms. There's a Staphylococcus, Klebsiella, and then Salmonella infection, Burkholderia, Serratia, and in fungal infection like Aspergillus and Candida are the same. So for leukocyte adhesion defect, we generally do a flow cytometry analysis of CD11A and 18. For CGD, we do two important tests. One is a nitroblue tetrazoline test and trihydrorhodamine test. So the nitroblue tetrazoline test can be done in any place that has a microscope. So all we need is like a 2 slide for a patient and a control sample. And we need a dye and a yeast. So it can be yeast or a PMA we can use. So generally, the dye will be yellow in color. So after, in case of stimulation with yeast, it will the dye will have a color change to blue. So due to the formation of parmesan. So that's what depicted in this 2 slides. So this is abnormal nitroblue tetrapoxylium test because they didn't have any parmesan formation. So this is a normal one. So this is a control side. Coming to the next thing, that is a dihydrorhodamine assay. So this is a flow cytometer based assay. So this we look for a shift in the fluorescence after reduction. So in case of CGD patient, there won't be any shift. So I put this flow cytometry because like in case of X-linked carriers, that is like mothers and sisters, they'll have double peak because like half of them will be like they are X-linked carriers. That is like half of the neutrophils will have a reduction and half of them won't. So they generally in flow cytometry is depicted as double peak. But in case of patients, there won't be any shift. So this is a normal flow cytometry in which we can see the This was before, the red one is the unstimulated one. The green one is the stimulated. So after stimulation, it has shifted. That is, they are having fluorescence. In case of patient, there is no shift. That means there is no reduction, dye reduction. And in case of carriers, that is the third graph, we can see a double peak. That is how the neutrophils are having activity and how them does not. So on the sequence of laboratory investigation that we do in CGD patients are like generally we do a hemogram and then we'll see a neutrophilic leukocytosis and we see elevated inflammatory markers. And for organism isolation, we can do microbiological investigation and radiological investigation. Later, we do a nitro-blue tetrazolium test or a flow cytometry DHR, and then we'll confirm it with a genetic analysis. So we do treat CGD patients with antibiotics and antifungals. So further, in the inflammatory manifestation in CGD patients, we treat it with steroids, and some patients with liver abscess, we give steroids up on top of antibiotics also. So these patients, once they are infection-free, we can give prophylaxis with Septran and Itraconazole. However, long-term and management is like bone marrow transplant, that is hematopoietic stem cell transplant. So the X-linked CGDs and all won't have a good survival without a transplant. So it's better to transplant all these patients. Coming to the vaccination in phagocytic defect, the one important thing, like I said before, so the live attenuated vaccines, even the BCG, they will not tolerate well. So these patients can have disseminated BCG risk. However, inactivated influenza vaccine is recommended in these cases. Coming to the next case. So in the next case is a 3-year-old girl who was symptomatic since 8 months of age with recurrent episodes of pneumonia, ear discharge, oral ulcers, and cutaneous ulcers. On investigation, we can see that the child was having neutropenia. The absolute lymphocyte count was 272. So this is a severe form of neutropenia this child had. So these are the serial neutrophil count that we have done for this child. So it's not like the child always had like a severe neutropenia. So in between, the child was having normal neutrophil counts, and then again it was dipping, and then again it was increasing. So this is a classical case of cyclical neutropenia. So generally, it's all depending upon the growth of the neutrophils. So they'll have an oscillatory period for almost 21 days plus or minus 4 days. So we have done a bone marrow for this child, which showed a maturation arrest, and a genetic diagnosis we have as alien mutation. So we recommend to do thrice a week or hemograms for this patient for at least 6 weeks to diagnose this cyclical neutropenia, to look for the cyclicity in these patients. So like I said, so the phagocytic disorders will have functional defects and the numbers, that is the neutropenias. So generally we say severe congenital neutropenia, if they have less than 1,500, they'll have myeloid maturation arrest in bone marrow. So these are the investigation we can do before a genetic diagnosis. And in case of cyclical neutropenia, we can look for the ANC and look for the cyclicity. In case of CGD, we look for in immunological investigation, we do NBT and DHR. In case of leukocyte adhesion defect, we do a flow cytometry to look for abnormalities in CD11 and CD18. In case of other deficiency like Shide-Kigashi, we look for granules in the neutrophil. We look for abnormal degranulation assay. That is also another flow cytometry. And we can look for a hair microscopy, which suggests a small mannaline granules that is homogeneously distributed. And it is not like it's the clumps of melanin we'll see. It's not like a fully homogenized melanin that we see in normal patients. And in MPO, there is again a DHR. If you do, they'll have abnormality. So coming to the next topic. So tuberculosis, we generally see like all of us, it's India. So it's a very common infection. And we generally say, yes, since we are in India, it's a developing country, we see tuberculosis as a common infection. But when to suspect inborn error of immunity in a patient who's having tuberculosis infection? So that is the next topic that we are going to see. So this is a case who had a BCG adenitis at 4.5 months of age. Then again at 1.5 years, the child had a pulmonary and abdominal TB with a gene expert positive. At 2.5 years of age, child had a pneumonia, hepatosplenomegaly. However, they are not able to isolate any mycobacterium or gene expert or MG. It was negative. In BAL, they have had Pseudomonas for this child. At 2 years, 8 months, the child had bone TB with lytic lesions in the hand, and FNAC of the liver also showed granulomas. The child again received ATT during this time. At 6 years, the child had pneumonia, and this time sputum was positive. So almost three times they were able to isolate or like pinpoint it is due to tuberculosis. And child has received thrice, like 4 times, almost 4 times the child has received ATT, and also for a prolonged duration. So this child had a BCG adenitis, disseminated BCG, bone TB due to an NTM, and also ATT4 courses. So the whole exome sequencing revealed interferon gamma R1 mutation, and the flow cytometry also was suggestive of decreased expression of interferon gamma R1 and decreased phosphostat1 expression, which is a downstream of interferon gamma R1. So again, coming to the question, tuberculosis is a common infection in India. So when do we suspect? So when the patient is having a recurrent tuberculosis, when there is a non-tubercular mycobacteria that has been isolated, when there is a disseminated tuberculosis, when there is a significant family history of tuberculosis, like 2-3 people are affected, and they also had a very stormy course or like a difficult to treat TB, and the response to it is not good, and the child keep on having the symptoms, either the lymphadenopathy or a hepatosplenomegaly, and it just keeps persistent. And the next question is, always a gene expert indicate mycobacterial tuberculosis infection. So we generally do AFB smear and a gene expert. So we think it is a MTB. So does always a gene expert means it's a tuberculosis infection? No, because like the gene expert detects a MTB complex. So the MTB complex has, apart from the Mycobacterium tuberculosis, they'll have Mycobacterium bovis, Mycobacterium africanum, Mycobacterium caneti, Mycobacterium caprae, Mycobacterium microti. So it's a complex. It involves like it can, when a gene export is positive, it means that it can be positive to any of these in infection. So why is it important? Because the treatment protocol changes for all of these infection. So in case of tuberculosis, we give a HRZD. In case of bovis, since bovis is inherently resistant to pyrazinamide, we give HRLE, and the duration also changes. For the rest of the mycobacterium, we have to modify ATT, and generally a second line drug, or like how we treat NTM based on the sensitivity we have to give. So we have to be very careful when a child has a recurrent tuberculosis, or the child was having disseminated like a lymphadenopathy, hepatosplenomegaly, and a fever, and you find a gene expert positive. That too in a small baby, we have to be aware whether it's a bovis or a tuberculosis. So coming to the next case. Next case is a 8-year-old. Next case, I think I have not mentioned the age. The child has come during 8 to 10 years only, but child had a multiple infections like bacterial infections, fungal infection. Child had autoimmunity in the form of autoimmune hemolytic anemia, lymphoproliferation. Child also was diagnosed with IBD. He had endocrinopathy in the form of decay and thyroiditis and arthritis. So when there are like so many symptoms with an infection and autoimmunity, so we generally call that as like a immune dysregulated disorder, or otherwise like ALPS or ALPS-like disorder. So nowadays the name it's called ALPAD, or few people say like it's a dysregulation in T regulatory cells. So it's called T regopathy. So I just put a slide just to show if a patient who are having a recurrent infection along with autoimmunity, then we have to think of something else. So that is something else is any inborn error of immunity that is similar to ALPS or ALPS-like disorder or a T-regopathy, like we call it. Coming to the next case. So the next case is a 5-year-old boy who had a discoid lupus at 2.5 years of age. And at 7 years, he had a CVT presented with seizures. And when we review the history, he also had 2 episodes of pneumonia. And in family history, the eldest sibling died of lupus at 7 years. So this is a very, this child also had a stormy course, and the sibling death suggested there is something behind this lupus. So on investigation, even though hemogram was normal, the thrombocyte was little on the lower side. We have done a complement levels. It was normal. And ANA that showed a 4+ speckle, and anti-dsDNA was negative, and APLA antibody was positive. So this investigation, rheumatologic investigation, I want everybody to remember that the child has ANA positivity but a dsDNA negative. But that doesn't rule out the child as having lupus. So this is a classical feature of monogenic lupus. So many of the monogenic lupus, they will have a dsDNA negative. Sometimes the complements can be normal also, based on where the deficiency is. So when to suspect a early onset or a early complement deficiency or a monogenic lupus? When they have early onset lupus, when there is a family history of early onset lupus. Generally, lupus is the one that commonly seen in females when a male child presented with the manifestation of lupus, when they have associated recurrent infection, when there is a predominant skin or CNS manifestation, and generally lupus will have a predominant nephrological manifestation, but the skin and CNS manifestations are only there, and their response to treatment is not good, then you should think of monogenic lupus. When the ANA was positive and dsDNA was negative, and complements can be normal, either a C3 or either C3 was low and C4 was normal, or like both can be normal, then we should think of monogenic lupus. So this child, why it is important? Because like the treatment changes. Because like these patients can be managed with giving, apart from the immunosuppressant, we can give them FFP replacement, or we can transplant the skin so that they can have a better quality of life. Coming to the next case. So this is a 4-year-old child with fever every month. So at 2 years, he had recurrent fever episodes and it was treated as viral. At 3 years, again, he was presented with fever, cough, oral ulcer, child was admitted. But the parents noticed that there is something abnormal. So it's like the child was having fever every 2 weeks. So on examination, this child had a high-grade fever. Child had sore throat, oral ulcers, and in occasional lymphadenitis also was there. Child had loss of appetite and irritability, but this child did not have any rash or GA symptoms. But in between the illness, the child was a well-looking boy. So this is not just a viral infection. So that is because of the periodic timing and clustering of symptoms, and we've diagnosed this child as a periodic fever after stomatitis, pharyngitis, and adenitis. This is one of the common autoinflammatory disorder. So generally it's seen is around 2 to 5 years of age, and males are more commonly involved compared to the females, and they briskly respond well to steroids. So in investigation, if we see during the period of febrile illness, the child will have neutrophilic leukocytosis with the TLCs were high, but during the afebrile period, the TLCs will drop down, the CRPs or the ESR will drop down, and they respond well with anti-inflammatory or single dose of steroids or tonsillectomy will help in these children. So coming to the next case, we have 2 or 3 more cases. So the next case is a 3-year-old girl who had recurrent fever, recurrent ulcers during the episode of fever, and the fever lasts for 5 to 6 days every 15 to 20 days. And the child also had ulcers and redness in the vulva-vaginal area, and there was some amount of dysuria. For this episode, child was treated multiple times as a UTI. Child was treated as a viral infection also. But we have noticed that during the time of this illness, apart from the ulcers and the child also had tender lymphadenopathy. So these were the investigations. In investigation, we can see during the time of fever, child was having high TLCs with the neutrophilic predominance, with the elevated inflammatory markers, and during the afebrile period, even whether we don't treat, the inflammatory markers were subsiding and the TLCs have become normalized. So this child was diagnosed with a hyper IgD syndrome. This is an mutation in MVK gene. So next topic of discussion is like when to suspect a periodic fever syndrome. Since we have seen a 2 cases of periodic fever, we will see. So autoinflammatory disorders generally present in childhood, but many patients present in a very early age group, like neonatal or from 2 months. Sometimes they'll have very early age of presentations also. But because initially they'll be treated as some infection, and later they come to us once the periodicity, the parents comes notice it, and then only they'll come to recognize. Some adult patients also can have autoinflammatory disorders, but due to a somatic mutation. So the fever is a usual and a dominant symptom, and they'll have a inflammation. So generally, they'll have a sterile inflammation. And if you do a biopsy or aspiration from any of the site, you will only see neutrophils and never you are able to isolate any organisms. So it can affect multiple organs like skin, joints, serosal membranes, meninges, inner ear, eyes, or GI tract. So there is an overlap of symptoms with the laboratory manifestation showing neutrophilic leukocytosis and elevated inflammatory markers. So this is the next case. So this is a 9-month-old girl who has been managed as recurrent osteomyelitis. Initially, it was involving the knee joint. So child has multiple antimicrobials. Later, we found that the child also have bony involvement in a lot of other joints involving ankle joint, and even in X-ray, the ribs were like the ends of the ribs were like distorted. So this child finally was diagnosed as a case of deficiency of IL-1RN, which we call this DIRA. This is due to a mutation in IL-1RN. So this child was managed with anakinra and doing well. So sometimes this can also be a presentation, a recurrent osteomyelitis that may not be an infection only. It's just an osteitis, just an inflammation. So this is a little busy slide. Just want to highlight there is one more disorder called ADA2 deficiency or DADA2. So this is also a spectrum of disorder. Even though the main spectrum is a rheumatological manifestation like a vasculitis-like presentation, they can have immunodeficiency-like presentation. They can have bone marrow failure symptoms. So no, not always the bone marrow failure symptoms or aplastic anemias only. Sometimes they'll have a IEI also. So this is a basic laboratory investigations, like how to evaluate inborn error of immunity, the first tier, second tier, and third tier test. So in case of complement deficiency, we do a C3, C4 levels, and then the second tier will be like to assess the functionality, we can do a CH50 and AH50. And third tier is always a genetic analysis. In case of antibody deficiency, IG profile and lymphocyte subset, and later B-cell immunophenotyping and vaccine responses we can do. In case of XLAs, we can do a BTK expression by flow cytometry. In combined immunodeficiency, it's always an IG profile and lymphocyte subset. And the second tier is the T-cell immunophenotyping or lymphocyte proliferation. In case of immune dysregulation, apart from IG profile and lymphocyte subset, we can look for DNT cells or Treg cells we can look for. In case of autoinflammatory disorders, we do cytokine levels or interferon signature, but generally these are available in research basis only. So whole exome sequencing will give an answer for these child. So I conclude by saying like common things are common, of course, but IEI is also not so uncommon. And it's always, we should rule out a secondary immunodeficiency. Sometimes the patient might have received steroids or some other immunosuppressants from outside, and you do an IG profile is low. It can be because of the drug only. So we have to have a detailed history. Sometimes it can be due to a retroviral infection. Sometimes because of nephrotic syndrome, they are losing all the immunoglobulins. So history should always help, and we should rule out secondary immunodeficiency before thinking of IEI. And I like to thank Kim's Cuddles for giving this opportunity. And I'll definitely thank my allergy immunology unit from PJ Chandigarh. Everything I am is because of them. Thank you so much.